Assalamu alaikum wa rahmatullah. Good evening and good morning, good afternoon to all colleagues who are listening to us for the MEOM webinar meetings. I would like to thank you all for being with us, and I would like to thank my colleagues. They are coming from different parts of the world. I have my dear friends also, Dr. Nadim Hussein, who will be the moderating of the sessions, and my dearest friend, Dr. George Rucca from Brazil, Titiana Benzova, Russia, Saudi Arabia now, and Dr. Ashraf Sharawi from Egypt. So today we are between or having a giant of vitreoretinal surgeon and high calibers. They are going to share their experience in challenging surgical retinal cases. And we will go through the new era that's we will ask everyone before he start to give a brief about himself, and also if he can give a talk or a small things about MEOM, his experience with MEOM. In addition to that, before we go to the scientific program, we will omit the first part, which is part of symposium for one company. They apologized to it 2 times, unfortunately. So we will go only with the directly to the main scientific meeting. Before that, also we want to share. Maybe we shared it last time, but we shared the final version of video of MEOM. So I will ask Abdullah, please, from BL, to share the final video of the last MEOM conference. Abdullah?
Okay, Dr. Muhammad, I'm sharing.
Okay, because I forgot to download to share from my side. I'd like to welcome you in Dubai, and we'd like to enjoy the meeting and enjoy the Dubai city. Thank you, and releasing the conference and the meeting. Thank you.
المؤتمر يمثل منصة علمية رائدة تسعى لتبادل الخبرات واستعراض أحدث الابتكارات والتقنيات في مجال الرؤية والعناية بالبصر.
I hope that you enjoy the video of 7th MEOM and waiting to see you all in 8th MEOM, which will be also in Dubai, October 30th to 1st of November 2026. Now we can start our speaker, their challenge and discussion of surgical cases. We will start alphabetically. So, Dr. Ashraf, you are okay to start?
Yeah, sure.
Okay, so before we start, Dr. Ashraf, if you don't mind, this is the way we need just to give a small introduction about yourself, then your small things about MEOM, and then you can go ahead, please.
Okay. I am Professor Ashraf Sharawi from Alexandria University, Egypt. And I had been working with the MEOM since about 3 years. Really, it's the meeting all the time makes a good connection between societies in Egypt and in UAE. And we had shared together to build like prizes for young ophthalmologists, young retina specialists to travel and to come to the Mayom and to share and see the experience of a very strong retinal meeting and in other subspecialty. And again, this cooperation is still going on up till now, and we are preparing for the next bridge meeting, which are going to collaborate with the Mayom, and the winners of the young ophthalmologists can have the chance to go to Dubai to share in the Mayom. And again, the people from the Mayom who win in young ophthalmologist competition can to Egypt to share in the Bridge Retina Congress. The Mayom meeting is not only a scientific, very strong meeting, but also it's a very nice place for social events and meeting old friends and making new friends. So I'm insisting from now to attend the next Mayom meeting, and we have very strong relation with Dr. Amri, who's sponsoring this Mayom Academy and spending much effort and time to keep the Mayom in the priority meetings all over the world.
Thank you, Dr. Ashraf. Your presence is highly appreciated and you are most welcome. You are an ad for the MEOM. And MEOM is a board. It's not only me. So it's go to all the administrator, executive committee. So we have many of them. And you have now two here. They are in this stage. They are part of the MEOM and supporting. One of them, Dr. George Roca. He is one of the in the executive committee, and he do a lot for us, sharing his experience and also his advices in all other things related to scientific program, to organization and other things. Titiana, she joined us also this year, and she is working very hard with us for this. So it is a or we can say a collaboration with many of high caliber speakers or high caliber specialized people, either in organization or scientific program. One of the most of these is Dr. Nazim, who is the General Secretary, and he's available with us. So thank you very much, Dr. Ashraf, and the floor for you. Thank you.
Well, every successful meeting all over the world should have a brain and muscles. Without this collaboration between the brain and the muscle, it will be a failure very soon. So I think you are doing a good job by joining other people like Dr. George and Dr. Nazim and Tatiana to give the meeting and the academy a very strong power. I will start my presentation and we are going to present some of the cases of the retina which we meet. And really, the beauty of the retinal surgery is that you don't find identical cases like each other. Every case has its special event and a special outcome, and you have to face all the problem you see during surgery and after surgery. And usually, the relation between you and the patient is a long life relationship, because usually the retinal patient does not go away from you, and you stays either you die or he dies, but you are going to have the patient all your time. So prepare yourself all the time to share the moments with your patient. I'm going to present some cases. Can you see my screen now?
Yeah, it's very clear, Doctor. Yeah, we can see it.
I'm going to present one of the cases, which is a 35-year-old female patient presented by left sudden diminution of vision. She is phakic, myopic, -8 diopter, anterior segment within normal. The other eye is free and myopic. And my rule in facing young myopic patients without PVD is just going for buckling as the primary step before skipping into other modalities. Especially this patient has a lower inferior retinal detachment with inferior retinal break. And the best way to buckle is to deal with inferior retinal breaks is to do buckling, because there is nothing that can support the inferior retinal breaks other than buckling. Sorry, this is still image at the beginning of the surgery. I didn't have the pre-operative images, but this is an inferior retinal detachment. And I went for my preferred technique, which is chandelier-assisted buckling. And as you can see, there is very small flap tear almost at the vitreous base, just before the ora serrata. I had cried the break, and you can see the twin chandelier light, the trokers placed. And then I placed an encircling band and drained the subretinal fluid. And as you can see, the retina is flat at the end of surgery, and you are dead sure that the break is well supported by the buckle. And this is a very good way to treat rheumatogenic retinal detachment in young myopic patients. And this was the post-operative appearance. As you can see, the buckle is well seen, and this was some gas, not gas, air in the vitreous cavity, because I have to inject some air at one point when the intraocular pressure goes down. However, 2 months later, the patient returned with this picture, PVR, total retinal detachment. And that's why you must know that your patients, the retina patients, are going to live with you for a very long time. And now the patient wants a solution. The vision had dropped to almost PL to hand motion because of this open funnel PVR. And I have to go for vitrectomy, dissect all the epiretinal membrane. In spite of spending much time to remove the epiretinal membrane, still the retina was very corrugated. I was thinking at this point that maybe I will go to retinectomy to settle the retina and to cut the shortened retina. However, at one point, I did try what we call the pneumohydraulic test, just doing air fluid exchange at this point and see if the retina is going to flatten or not. And as you can see, the retina went back its place. I was able to place my endolaser, which is a very good test that the retina is attached, and I had replaced the air by silicone oil. And again, this is my preferred technique to do the laser under the silicone oil because it gives very good clarity of the retina during this procedure. And this was the post-operative appearance, the fundus picture. As you can see, still there are some proliferation along the inferior temporal arcade, but the macula on OST is completely flat. So, and the patient had a visual improvement to like 560, and I thought that this is very good for her. However, during the follow-up, there are more proliferation along the infratemporal arcade. And as you can see, the site of the retinotomy, which I placed the laser on it, are starting to open. Although the buccal is seen inferiorly, but still there are a proliferative process which is severe, affecting the intra-epiretinal and subretinal space. So I went back and removed the lens because it did come cataractus, as you can see, and went back to try to remove the proliferation. However, the proliferation are intraretinal, and some of this proliferation are very, very close to the optic disc, especially inferiorly and on the nasal side. And I did do a retinectomy at this point, trying to release all the traction and to overcome the shortening of the retina. After flattening of the retina under PFC, again, I did try to remove any residual membranes, but as you can see on the nasal side, it's just intraretinal and subretinal. You can never remove it. Otherwise, you are going to destroy the whole retina. So I did do my laser to the residual retina after complete removal of the peripheral part of the retina. And this was the post-operative appearance. Again, the macula went back in its place. And there is residual proliferation, as you can see, and as we had agreed. But however, the fovea is attached, and the patient is enjoying a visual acuity of like 460. Again, I did follow the patient for the next 3 months, and the fovea was attached, but still, as you look inferiorly, it looks angry. And this was the picture 6 months later. The fovea is attached with a very angry retina. The question now, this patient is having silicone oil. Do you agree at any point to remove this silicone? For me, I don't have the term for these patients to remove the silicone. I have the term of silicone oil exchange. So if I'm obliged to remove the silicone because of emulsification or increased intraocular pressure, I would go for silicone oil exchange because I know for sure that the retina would detach after the surgery. Thank you. For this case, I have other cases, but you may ask the discussion about these cases, about the point of removal of silicone in such a case.
Thank you very much, Dr. Ashraf, for this excellent presentation and very difficult case. And I think all colleagues now, they will give insight, and Dr. Nazim, he will take over from here about surgery discussions and others.
Yeah, thank you very much, Dr. Ashraf. It's a very difficult case. Obviously, in most of the myopic eyes, we often end up with surprises. And I have a few questions. What was the axial length of this patient, number one? Number two, why do you think in your case there was so much of inflammatory membranes which has happened and which does happen in eyes? And your question that would you remove the oil? I wouldn't remove the oil unless there is a secondary changes because of the oil. I might replace the oil if it is maintaining some kind of a navigable vision. So your questions that I asked you.
Well, the axial length of the patient actually was not that high. I think it was around 24 millimeters. So she is not a very high myope. As you can see, there is no much myopic changes on the optic disc or in the macula in very high myopic or posterior staphyloma. The point of silicone oil removal, we must agree that there is something called silicone oil exchange. You just remove the silicone and re-inject it at the same setting. Because if you leave this patient without silicone oil, then the retina would detach and you will lose the ambulatory vision by the fovea, which I think in this case was around 460. This is very important, especially if you are dealing with one-eyed patients whom the problem is much grave. You don't sacrifice this vision by any way.
Why do you think is the reason for this aggressive behavior after initial buckling? In such a wonderful surgery which was done, you have closed the hole with the cryo, you put a buckle inferiorly.
I think that there are some patients who have PVR tendency, like a gene for PVR, like the patient with proliferative diabetic retinopathy. Patients with very long history of diabetic retinopathy, you don't get the diabetic retinopathy, but we have here in Egypt some places, which is especially near Libya, who have a gene of very aggressive diabetic changes. The PVR, I think, is a gene of scarring or proliferation, which is present inherited in this patient. As you look, this patient is not that high myope that you are thinking about problems. The surgery would have passed very smoothly without problem if this patient didn't have this gene of proliferation.
Thank you. I would put the question to the panelists, to both to Tatiana and George,
I think
regarding
Dr.
this.
Nadim, Dr. George, and Titiana, they are raising hand for a comment. So
Okay.
we can
Is
go
it
to
possible?
George.
Thank
Yeah.
you so much. Great presentation, and it hurts all of us because all of us has such kind of patient. They are remembered for life. I totally agree that there is some tendency. We can ask such kind of patients about scar on the skin. Do they have special tendency? Collagenopathy, a systemic disease. And after that, administer immunosuppressive therapy or put inside the silicone oil cytostatics medication. And I totally agree that the best solution is to leave or exchange silicone oil. Otherwise, we may lose everything, some islands of vision, and get the hypotony. Thank you so much.
Okay. Dr. George?
Dr. Sharawi, congratulations. Very tough case, beautiful case. Everyone face such a challenge in our profession because it's impossible not operating retina detachment without facing patients that has tendency for PVR, and PVR is something terrible. Some advantage can stimulate PVR, like if you have blood in the cavity or using cryo that can disperse RPE on the cavity, and sometimes it's just good just to drain, put a buccal and laser in the second time. And patients like this, I used to use methotrexate for 2 months or more every week, around 400 micrograms, and I have very good results. I have now more than 25 cases with using methotrexate, and I think it's help. I think the question is, oil will never be a choice to take out from this eye, because if you remove this oil, they can shrink the eye. But if you have secondary glaucoma or any other side effects, you have to just exchange the oil. And sometimes they still has some proliferation, and this macula are gonna be detached, and then you have to return and remove some scar tissue to reattach the macula. And sometimes we can do this under the oil. Steve Charles taught us how to handle some scar tissue operating without remove totally the oil. But beautiful case, very challenged. I agree that's you did the best. Thank you.
Thank you very much. Thank you. Can I go ahead for the second case, or I don't have time?
I think we can go one case per each one. If we have a time, then we can go again and repeat. What do you
Okay.
think, Dr. Nadim?
Yeah, we need to do that.
Okay. I want to ask one question. I know maybe it's not my area, but for Dr. Ashraf, the other eye of this patient is normal or having some issue in the other eye?
Just myopic patient. Just
And
myopic. I think it was like -8 diopter,
and visual acuity is good.
and visual acuity is good.
Okay, I don't know. Is it worth, for example, to do a 3 surgery for the patient and the visual acuity outcomes only counting finger?
Well, you
If the
don't.
other eye is normal, I'm saying if the other eye is
You
normal.
will never know what's going to happen with the other eye. I mean, maybe the same scenario is going to be repeated in the other eye, and you may not be able to save. Maybe you are not able to save even this 460 vision in the other eye, and then the patient will be in trouble. So I think it's worth to try, even if the visual acuity is not that good.
I
But
ask this question because of something I want to pass one message. This patient is a young because he's a 35. So it's worth to do 1, 2, 3, and 4 surgery to save whatever the time because he is having, I mean, a long life. Hopefully that's, I mean, more times. He's a young, productive time, working time. So I think, yeah, that I ask question just in that to say that we need to do the surgery as much as we can to save whatever the amount of vision that we can save for the patient. This is my opinion. If you all agree or you have any comment on that.
We agree. Even a young patient, that is why whenever you see a patient post-trauma, which is so badly a globe rupture, it has an RD, you try to repair in these young people, even the RD, you repeat the surgery to keep some amount of navigable vision there, best because you can never know. He has a long years of life. In the good eye, in the future, what may happen. That's one. And number two, there is always a 20 to 30% incidence of having the other eye retinal detachment in the future in an eye like this. And often in our career, we do see when they come to us, the one eye operated multiple times, a lost vision, the other eye within a year or two come back with a retinal detachment, and you have to operate that eye, learning the lesson from the other eye. So yes, answer the questions.
There is last question from my BVR. Is there is a way, I mean, to decrease or minimize a BVR happening after VR surgery in these cases to avoid this complication and do again and again surgical intervention?
George can answer that. He partially has
Yeah, I want
answered.
to. Yeah.
Nowadays, many people are using methotrexate that may decrease the RPE changing for scar, and then
It is
has
intravitreal or intravenous?
intravitreous. You inject
Intravitreal.
under the oil every week for 2 or 3 months. And now has some people using melphalan, another anti-metabolic drug for cancer that are using for the same purpose to decrease the formation of scar. And these things can helps a little in such a case. And the other thing that people are discussing is when you have this patient that's very reactive and try to decrease the inflammation inside the eye during the surgery. For example, some people just remove all the scar tissue and flat the retina, put oil and no laser, and do laser, for example, 4 weeks after the surgery, just to not stimulate the RPE to change for scar tissue. And then some action like this can decrease a little the changing for create more scars, more destruction of the retina. But it's not easy. We don't have right now the cure for PVR. Some patients still have this fate, and then I think the only thing we should do is operating. Some people says that after 5 surgery, the PVR will calm down and you're gonna stay quite well, but it's not true. Sometimes they still come back even with very good hands that clean all the scar tissue.
Thank you very much, George. Thank you, Dr. Ashraf, for this very informative and challenging case, really challenging case. Okay, Dr. Nadim, next.
Yeah, so I may request George to present his case.
Yeah, he will introduce himself first and give some information.
Mention our MEOM.
Yeah.
Well, I'm George Rocha, a retina surgeon in Brazil. I'm located in the northeast of Brazil, that is the city of Salvador. And I also, in the board meeting of MEOM, executive board, also as a treasurer board in the RWC. And it's really great pleasure to be here among the best. MEOM excites me because this hard work that all you have done has create a beautiful meeting that is the center of the world. Dubai, MEOM is the center of the ophthalmology world in the East. And I do believe that this thing is continuous growing and growing because have the energy of friendship, the energy of people that believe in science and exchange culture and continuous stimulating research for the patients. Congratulations, all you have done, Mohammed, Nazim, and everyone that's in the board of the MEOM, because my experience in MEOM was something unforgettable. We have the chance to connect with people from everywhere. We have the chance to exchange ideas, exchange knowledge, and debate for doing the best. Really, I advise you come to MEOM because the 8th edition gonna be much better than the 7th edition. I believe so. And well, if you allow me, I can just share my case here. Let's see. Can you see my slides? Well, that's good for you?
Yeah, very clear.
Oh, good. Let's bring a case that my friend asked me to discuss. I hope you can enjoy this. This is my disclosures. And now I have the privilege to be among the best of the retina surgeons in the world in this MEOM section. Thank you so much for allowing me and invite me. And don't forget, MEOM is coming, and the next edition will be much better than the other ones. And this is the case that everybody face, is the retinal detachment follow macular hole pars plana vitrectomy in a 62 years old pseudophakic pars plana previously vitrectomy with macula off, and this right eye has OD, has just movement, and 30 days after the surgery, the macula was attached and the macular hole was closed. And then what I tried to do, the surgery, I just put a buckle, a band, 3/6 band, and I put some PFO to settle down the retina and start to clean the very meticulous the vitreous base in order to try to find some hole, some tear, some break, but nothing. I cleaned all the vitreous base very meticulously, but nothing happened. I didn't find. And then I just choose to make a retinectomy and drain the fluid, make the retina flat, laser the hole, and after laser the retinectomy hole, I just start to laser 3/6 because didn't find the original break, and then I just think, oh, I may get better if I just laser everything and try to by chance hit this break that I cannot see. And then at the end, I tamponate with oil. My idea is if I put oil, I have settled down this and for a while, and after 2 months, I remove the oil, and the patient has 260 vision. And for discussion, the first question is how to find a small retina break. Sometimes you can look around really meticulously, but sometimes you don't find. And what techniques I can do for trying to find these small retina breaks. Some people are using brilliant blue. Some people are inject under the retina because when you put under the retina and you just put PFO, the flow of the blue can just make you see some small breaks. The others can use the brilliant blue inside the vitreous cavity, and after you just start to put the PFO, this can also make some difference in the flow with the blue, and you can find these small breaks. But it's something that's it's not easy, even with all very skilled retina surgeon. Drainage. I use retinectomy for drain, but some people are used just put a needle in the subretinal space and put the air with the air pressure. This can pump the subretinal fluid, and you don't need to do a retinectomy. That can cause some PVR. Photocoagulation. Some people think that is use 360 degrees photocoagulation when you don't find the road, the break, but it's something that's is by chance. You don't have really, you are not 100% sure that you hit this break. And tamponade, we can use oil, but it's not wrong to use gas like C3FA. Just open for your discussion.
So let's ask everyone on the first
Hear you.
question.
Cannot hear you.
You can hear?
Yeah, good.
Yeah. So let us start from the first question. How do you find a small retinal break, which if you don't find any with the buckle in place in this case? So let's start with Tatiana. How would you approach this to find the break? Or
Am I right? We are
you,
talking about intravitreal approach.
yes, vitrectomy.
Yeah, I would. Sometimes it's impossible to discover because it closed. It was so small and now it's closed. But if we put PFCL, heavy liquid, to flatten the retina and do it gradually, increase it gradually, slowly, we can find the flow of yellowish liquid, one of the way. Also, could I answer all questions?
Sure,
One by
go
one,
ahead.
one by one.
Okay. I would increase the bubble of PFCL gradually, but sometimes it's impossible. Plus, find with scleral compressor 360.
Yeah, Dr. Ashraf, do you have any other view? You are muted.
Dr. Ashraf, you are muted. Unmute.
Well, for me, the problem of missing a small retinal break had decreased very much since the introduction of the wide field photography. One is that, the other is chandelier assisted buckling. Because during a chandelier assisted buckling, as you had seen in the first case, you can deeply clear the press, the peripheral retina up to the ora serrata, and even if a very small break at the ora serrata, you can see it. And for me, if you don't find a retinal break, then the question is going to be raised if it's really a rheumatogenic retinal detachment or an exudative, because you have to find a retinal break. And the examination of the retina with deep scleral depression and the magnification and the fine focus of the operating microscopes makes your life much easier in detecting a very small retinal break. The other point is that pseudophakic is not a prerequisite for vitrectomy. Even cases of pseudophakia with no PVR and no complications during the surgery for cataracts, you can still go for scleral buckling under chandelier, and you can fix these breaks. For me, the question is going either to vitrectomy or buckling is the presence of PVR or anterior segment complication of the previous surgery. The second point is drainage. Yes, I drain, but I don't drain internally. So I'm draining externally, that like the first case I had showed. And if you don't find a retinal break and then you are going to create a break for yourself, then you are complicating the problem. Photocoagulation 360 degree or not, I don't think that this has any role in preventing the retinal detachment, because if there is a retinal break which by chance was missed even with the 360 degree laser, then you will get recurrence. You have to search for the break by very deep scale indentation and examination under the operating microscope. For me, the point of tamponade is depending upon the situation. If the patient is one-eyed, then I go for silicone. If he has some PVR, I will go for silicone. But if it's just rheumatogenic retinal detachment, I may go to even air or gas.
I think, Tatiana, we interrupt you, so you can go for the other points.
Yeah.
No, interrupt. Thank you. I would add that in phakic eyes, we have to assume the right location of break according to Linkoff rules also. According to, in terms of drainage, if we are talking about intravitreal approach, I would do retinotomy and drain. Would do it in nasal, upper nasal quadrant. And then if I don't know the right location of missed break, I would do 360. But I don't do it routinely, of course. Temperament
If
also depends on mobility of the retina, presence of PVR. Sometimes you feel that it's from upper part. It's difficult to explain, but you feel it's not inferior break caused such kind of detachment. So it's not easy to say 100% I would do like this, but it's the approach.
I have just to highlight that this retinal detachment was secondary vitrectomy for macular hole. And
Ah,
I
that's
this is the difference that we are not discussing just a buccal, because this patient has already vitrectomy, and then was a complication for this vitrectomy, and then we remove a great part of the vitreous, and then in this situation that you have retinal detachment, we need to go inside, just because if you leave the vitreous gonna be much worse, and we have to search for the hole. I agree. Dr. Sharav said that intraoperative microscope search is very important, but sometimes, as Tatiana highlights, the hole is so small, the break is so small that they close, and people are using brilliant blue is other way to try to see this flow that Tatiana just explained brilliantly, that you just put the PFO very slowly and try to find out the flow. And sometimes when you just stain with brilliant blue, you can see some people inject underneath the retina to highlight the blue flow, or some people just put in the cavity to make this yellow flow that come from the under retina be more effective view. But this was a complication of macular hole, and I agree that's the best way is to find the hole, to make the perform the laser for exclusively in this break. But sometimes if you don't really find, do 360 laser is by chance. We don't have 100% sure, but one option that's happened. We can do in many different ways for the same problem, but is one option.
I think what George did it is a post macular surgery, and often it may happen if you have experience. I have faced it. So after the macular surgery, the patient comes with retinal detachment a few months later, and many times because you did a vitrectomy, you might have created a very small hole somewhere, which has happened over time, and this slow seepage of fluid under the retina will slowly, gradually becomes a retinal detachment until it got detached and a patient comes to you. By the time it gets detached and symptomatic patient comes to you, the small hole, if it's near the vitreous base or whatever, it gets closed. So what you did, I think it's very good that you put the buckle on, and then as you put the PF cell, and I also do the same, I will put the PF cell up to the edge of the buckle and put that small retinotomy on the buckle and drain the buckle fluid and then take the fluid out from the posterior. I prefer not to do any retinotomy behind. I prefer to drain always from the periphery. So that also helps me to do less laser photocoagulation. And obviously, if you don't find a hole, I also do not very heavy, but light laser over the buccal. So I think your case was different. That is why it was taken otherwise. But if it's a primary retinal detachment, which is you don't find the hole, then all of the discussion which we did, and that pertains to that. So I think it's a wonderful case. So all of us missed out that it was post macula hole surgery.
I think
So
Dr. Ashraf, you want to have another comment.
Who?
Dr. Ashraf,
yeah, unmute.
unmute. Dr. Ashraf, you are muted.
This is very important. The case had George had presented because of two things. We should highlight very importantly that during vitrectomy, even for mild condition like the macular hole, you have to examine the peripheral retina very accurately at the end of the surgery because you may miss a very small sclerotomy related break, which I think was the case in this patient. And this causes post-operative rhegmatogenous retinal attachment and very difficult to visualize. The other point is that retinal detachment after vitrectomy is a very important emergency condition in the vitreoretinal world. When you get detachment in the vitrectomized eye, you have to operate immediately because there is no vitreous that stops the retina from progression, but the retina detaches so rapidly and actually it adheres to itself. So if you leave the patient for 2 or 3 days after this instance, you may end by inoperable case. So there are two lessons which we should learn from George's case. One is the sclerotomy related breaks. The other is the emergent condition of doing vitrectomy in patients with detachment following vitrectomy.
Wonderful. Yeah,
Thank you.
Mohammed.
Very nice discussion, and you raise very important points for us.
And I would like to add perfect picture. Artificial intelligence repair of the eye.
Oh.
Perfect.
Thank you. Thank you. Just to finish the case,
Yeah.
invite everyone for the Brasilia Vitreous Retina Society 50 years. That's going to be São Paulo next year. But do not forget to buy 2026, 30 to the 1st. Thank you so much.
Nazim.
Yeah, may I invite now Dr. Tatiana? Please introduce yourself and you may add some few words on your MEOM participation, your experience.
Thank you so much. Thank you, dear all colleagues, all participants. My name is Tatiana Vanesova. I've been working as ophthalmologist for 20 years, as a vitreoretinal surgeon for 15 years in Moscow. I'm from Russia. But this autumn, I started new chapter, interesting chapter in my life. I've been working in Saudi Arabia, Dahran Eye Specialist Hospital since September. It's interesting country, beautiful culture, very, very kind people. I am the member of board, MEOM conference, and I visited it twice, and I saw the difference between 2 years. This year, all conferences were covered not only retina subspecialty but all. It's very nice to visit rooms with respected mentors, lectors, and to listen to other parts of ophthalmology. Also, it's incredible place for combination, cooperation between young and experienced skilled surgeons, not only surgeons, doctors. And this year, I found that it's so great to have competition and prizes. We were as a kids when we saw the winners of a lot of competition. It was so nice, joyful, and it's great when we combine serious science with this competitive interest. Thank you so much for including me in the board. I'm going to continue and to come next November visit MEOM conference. As I told you, I'm in Saudi Arabia now, and my professional life also changed. Can I share?
Yes, please go ahead.
Can you see? Yes, can you see?
Yes, Titiana, go ahead.
So, in my professional life, there have been a large number of patients with tractional retinal detachment who present very, very late. Even they have almost, maybe not all of them, but a lot of them have only one single eye. In addition, the Gulf region is home of the disease and its trait known as sickle cell anemia. So my case is about the patient who has tractional retinal detachment, who is a diabetic patient. At the same time, she has sickle cell anemia. This is her worst eye, left eye. Right eye is good. It's treated by laser. She has non-proliferative diabetic retinopathy on her right eye, and left eye is pseudophakic. Has tractional tabletop, as you see, and B-scan picture, retina detachment. She has renal failure. She on dialysis 3 times per week. Also, she on anticoagulants, and it's impossible to cancel because it's mandatory. So this is the picture, and we recommend her make surgery. I did pre-op ELIA 4 times prior, and then went to the surgery. Start from cleaning vitreous. It was quite old vitreous hemorrhage. It was not so easy to decide to make surgery for her and for her family. After cleaning vitreous hemorrhage, I found that there is fibrovascular membrane, that I start with local detachments on arcades. I started delaminate these membranes, accurately lift the hyaloid, and what I found, it's quite healthy macula. It seemed like it was waiting for this realize. At the same time, you can see the clots that were not spread, but were quite sticky. It was difficult to remove these clots. Continue with segmentation, delamination, chandelier assisted by manual work with forceps, scissors. There was also separate detachment. It looks like rhigmatogenous. That's why I drainage and put silicone oil. In post-op period, we faced to incredible, extremely high IOP, even 70. It was number in IKEA, and Goldman also showed us incredible numbers of IOP. There are some publication in literature that such kind of patients may have ghost cell glaucoma. It's difficult to understand what type of glaucoma she has, because we found high IOP on her fellow eye. Maybe it's decompensation of primary glaucoma, but even maximum anti-glaucoma medication did not help. That's why we decided to remove silicone oil in 1 month. And fortunately, we got good result, her visual acuity 20/50, and she has now she has such picture of retina. We are happy, she is happy also. And it's difficult to understand what is the root cause of tractional detachment. Is it microangiopathy of diabetic process, or whether occlusive disease of sickle cell anemia? But she's nice, and her IOP is good on maximum anti-glaucoma medication. Again, thank you for your kind invitation and for your attention.
Yeah, wonderful case study. I think you have a mixture of traction detachment, but I'm not very sure how much is the sickle cell disease causing the traction detachment, because the way it is, but you must have operated it, because most of the sickle cell disease, they will have their C-fan proliferation mostly in the equatorial region. So you have the tabletop detachment with fibrosis. Probably the fibrosis is more because you gave Eylea. So what do you think when you are operating? Was sickle cell disease was also part of this traction detachment when you are doing?
I think no, I think it's more for diabetic, but according to anticoagulants, it was not easy to avoid such kind of clots, not clots, bleeding. Yeah, I agree that proliferative sickle cell retinopathy usually we can see in equator zone more than in posterior pole. But I have other patients that showed us the central tractional fibrovascular tissue with
So
sickle
what is
cell
your,
anemia.
yeah, I would put it in the panel as well as first to you, as you have already handled this patient, which is an anticoagulant, you cannot stop it. But what precaution do you take in patients who are with anticoagulant, like on clopidogrel, or I think the plato receptor blocker, or in Brilinta? What did you do in those patients? Do you stop it for a few days and then continue a few days later, or you cannot stop it because they need it, or you have those heparinized, because these are also dialysis patients? So would you do a non-heparinized dialysis before you do the surgery, the one dialysis before? Do you take any precautions like that before you operate in such kind of morbid patients?
Is it question for me?
Yeah, first to you, then the
Yeah.
rest.
Yes. It depends on internal medicine consultant. I would follow the recommendation. Even for this patient, I got a letter, try not to cancel anticoagulants. It was mandatory. She's quite sick, and even dialysis process. I tried to make surgery in between the dialysis session. This is the way to see the patient, make sure that she can follow the ward, and I can observe her after the surgery. So there is no one way for such kind of patient. But if it's possible, I try to cancel anticoagulants for 3 days before surgery.
Okay. Dr. Ashraf, George, anyone?
Well, the question about anticoagulation, I prefer to stop. Depends which type of anticoagulation anticoagulant drug you are using. You need more time or less time without drug. Like if you use aspirin, you need at least 15 days, but if you use heparin, just 24 hours. These new ones that you are just told about us, I believe the 3 or 4 days before stop is good, because we are dealing with a lot of neovascularization. And in the old time, I have experience to have unstoppable bleeding during the surgery. I have to stop the surgery and postpone the surgery for 2 weeks and operate these patients. And then I prefer to stop this for sure.
What about the patient? Like this patient was on dialysis. So most of the dialysis, hemodialysis are done on heparin. So do you discuss with your nephrologist that you want to half dose the heparin, or do you discuss with them, they suggest you do a non-heparinized one dialysis before you do the surgery?
I used to discuss with the nephrologist about how to deal, customize each patient, but usually they allowed us stop heparin for 24 hours before the surgery, or use the high molecular heparin that's we can stop only 6 hours before the surgery. But we need to discuss with the nephrologist the best way to handle each patient, because if you go with heparin inside with all this neovascularization, it will be something that you can't stop, and then you have to lose the eye because of bleeding.
Yeah, Dr. Ashraf?
Yeah, this case is very nice demonstration of the dilemma we face before vitrectomy for patients who are in morbid situation like this diabetic patient. But I think that you should stop the anticoagulants if it's platelet inhibitor at least for 1 week, because it has a very long working time. The other point about the diabetic vitrectomy for diabetic retinopathy is one that bimanual surgery is mandatory for several reasons, because the retina is very thin and you have to remove the membrane completely without exerting traction on the retina. The other benefit of bimanual surgery in proliferative diabetic retinopathy, as Tatiana showed us, there is almost always bleeding which clots on the surface of the retina in few seconds and form a clot of fibrin, which is very difficult to remove, even more difficult than the original membranes. So you have to have a venting instrument in your one of your hands to clear the blood all the time. Don't leave it to the end. If you leave this blood to the end, then you will end with an amalgam attached to the macula directly, because it goes directly to the macula where the patient is in the supine position, and you have to clean it all the time. The other point is that all the diabetic traction detachment have what we call the vitreoskisis, or splitting of the vitreous. And for me, removal of the posterior leaflet is as important as removal of the anterior leaflet, because this leaflet, if you leave it, it contracts in the post-operative period and it creates break, and it creates recurrent retinal vitreous hemorrhage, because it exerts traction on even the residual neovascularization inside the retinal tissue. One final point in diabetic retinopathy is that use of tamponade is very forgiving as far as you had removed everything. So if you are successful in removal of the fibrovascular proliferation, the anterior leaflet of the vitreous, the posterior leaflet, you can even use air, not
Gas
even
air.
because the retina in diabetic retinopathy is different from PVR It does not have the contractile intraretinal tissue like the PVR. Just if you remove the surface attachment of everything, you are in a safe way to just use air without the need for a long-term tamponade. And if you think that using silicone oil in such tough cases is an escape, no, it does not give you an escape. You get proliferation even after the silicone oil, and you get redetachment even under the silicone oil. So try in diabetic especially to remove everything as long as you can do it, even if you are going to create a retinal break, as long as it's not in the macula. Anywhere in the retina, create a retina break and remove everything. Don't leave anything. And laser these breaks, and you can use then air or gas or whatever, but don't reserve the silicone oil for the cases in which you failed to remove all the proliferation, because actually it contracts and causes redetachment under the silicone oil.
I think wonderful. I think Dr. Ashraf, you have highlighted very few important points in terms of basic physiology. I would because these are very important about the blood clot, about the plasma which comes out, and proper removal of the membranes, and use of silicone oil on these factors, because plasma, when it comes out, and membranes which are already there, it increases the inflammatory cytokines. And the moment you put a silicone oil induces inflammation to a certain extent. That is why you get a pericyclic proliferation, so many things. So inflammation is an important part. And inadequately cleaning, leaving behind blood with the silicone oil increases all these inflammatory cytokines, and you know the consequence of what happens. So it's very important to understand that, and you have highlighted that. Wonderful. And at the end of the day, Tatiana did a good job, and Retina looks wonderful. And I think, Dr. Asher, you want to speak something? I thought you want to say something.
Yeah. I just want to show you one case of PDR in the post-operative period in which silicone oil was injected in spite of residual proliferation and what had happened in the case. So
Yeah,
just
Muhammad,
give me
you are
just
muted.
I'm muted.
No, no,
No,
no.
Muhammad.
Okay, yeah, Dr. Ashraf, we can go very fast on this case. No
Yeah.
problem.
Okay, I will show just the post-operative result because it's very striking about the use of silicone oil, just to be sure that you had tamponated the macula or the retina, but actually you had created a problem for yourself. The retina is going to detach under the silicone, and it will be in very bad shape to reoperate these cases. Just give me few seconds and I will be ready. Retina vitrectomy in diabetic.
We cannot see your
Yeah,
video.
I'm still searching for the slide. You have to just give me.
Could I add? I totally agree, because now I have a lot of ugly TRD cases. I totally agree that air works in other fashion in such kind of TRD. Really, it's fantastic to see the flat retina, and you don't need second surgery. It really works. Even I know that some surgeons prefer finish with BSS. Maybe it's my next step. But yeah, really fantastic. Even no need to use gas. And I also had a patient that I decided to put silicone oil because he had bilateral tractional detachment. I just wanted him to give vision next day after the surgery. That was my goal. And I regret. I've never done like this. It's not it's not right wish to do it. We have to know that the only indication for silicone oil, it's something happen in inferior part of retina. It breaks. It should be medical condition, not surgical, not social. Because after that he had also a lot of problem because of the silicone oil. Blood was diluted under the silicone oil, and it was inflammation. I removed silicone oil. He was happy for 1 month. Then he came with ugly PVR and macular hole, and it was his one eye. Now he's quite good. Of course, vision acuity is poor, but I'm thinking about second eye, about fellow eye. He's also incredible LP, but I try to do best in this eye. That's why I understood no need to put silicone oil, just for good wow effect for next day, even for bilateral blind patients.
Yeah, I
I
agree.
agree.
I'm ready now to show you the slide. This is the case. Can you see it?
Yes.
You can see, Dr. Ashraf.
Yeah.
Yeah.
Just putting the silicone, you can tamponade
Nice
the
title.
macula, but as you can see, the whole periphery is detached, and someday, somehow, the peripheral detachment will come on and take the macula off. So silicone oil is not an excuse for tamponading the retina. You should remove this proliferation first and then use whatever you need.
Absolutely. I think Dr. Asha spoke from his years of experience that you cannot replace a proper meticulous surgery just to take the rescue of silicone oil. No. And with time, we have understood that silicone oil causes so much of inflammation. And especially in the eye with bleeds, there is plasma coming out. No, that's not the answer. So the answer is a proper meticulous surgery, and that is the key to the success for everything. And that, I think, is a basic learning for all of us. And that is what Dr. Ashraf has shown here in this picture. And the number two, what Tatiana has said is absolutely correct. I never use oil in my diabetic patient. I just see that I don't create a hole in any traction detachment. I just put a bubble of air, and with time the retina retracts back. And yes, because of the traction detachment been there for some time, so your subretinal fluid is little more protein in nature. So it takes time, but when it settles down with ease. So I think the key, release all the traction, don't create any hole, and put a bubble of air, and the air will go away in 4 or 5 days. I think that's the good thing, unless you have an extensive traction where you need some little longer tamponade, and that works out well. It reduces the chance of inflammation. I think in all respect of many disease, the inflammation has played a very good role, and the understanding is coming to all of us, whether it is in AMD or whether it is in diabetic retinopathy. Also, inflammation plays a role, as well as your oxidation or oxidative damage. I think we all understand that, and with time, I think the use of oil has gradually reduced. And even though it is used, people are removing it early, just to let the laser heal. And anyone has any last comments? And then Mohammed can give the last say.
Just for the last comment, Tatiana, you did a very good job. You are dealing with two disease, diabetic and sickle cell, that is ischemic disease. And about the problem with the IOP, we have three possible situation. One is the oil blocks the pupil, and we need to do iridectomy to release the flow. The other thing that you said is the ghost cells glaucoma that can happen. And the third thing that I had once, when we operate such a ischemic patient, sometimes when you go in, this patient are starting new vascularization in the trabecular site. And then you finish the surgery, you did laser, and then you're gonna shrink these new vessels, but the flow is compromised. And sometimes this patient, only thing that you can do is put a glaucoma device, like Ahmed tube and anything like this. But you did very good. And this, I had some patient, because in my country has a lot of sickle cell disease here. We have some very bad ischemic case like you did. And this, the last thing, have to take care with the optic nerve ischemic, because if you operate this case with intraocular normal pressure, I mean 30 millimeters of mercury in the intraocular pressure, maybe we can have a beautiful case, but you have a ischemic optic nerve. And then I used to operate this case with very low intraocular pressure, like 20 or less, just because to prevent to have uneventfully optic nerve ischemia in the post-operative period. Thank you so much. It was a beautiful case.
Thank you for your comments. Thanks.
Okay, Nadim, okay, we can finalize.
Yeah, you go.
Great
Thank you
webinar.
very much for this incredible discussions and cases. I think if we have a time, maybe we'll spend 1 hour, and I know we will not stop because the cases
Not
is,
sleep.
yeah,
Yeah.
Sleep and work tomorrow.
very
Sleep today,
nice
just in
cases.
case.
Yeah. Thank you, Dr. Ashraf. Thank you, Dr. George, Dr. Titiana, Dr. Nadim, and for BL for this very nice, informative sessions. I think before we move, just we have to draw the winner of the today. We will select one winner for free registration in the MEOM, coming MEOM. If you are ready, okay, so make it stronger. Okay.
Strong.
Congrats.
Okay, so congratulations for Kunoon Saleh
Great.
for
Congratulations.
having a free registration for 8th MEOM conference next year, 2026. They will contact you and send you the email about this one in very soon. At the end of this, I would like to thank you all. It was a pleasure to see you all also, and we hope to see you somewhere in a person also in Egypt or in Brazil, maybe in Saudi Arabia or here in Dubai. Thank you all and see you. Assalamu alaikum. Goodbye. Good
Great.
night.
Thank you so
Bye.
much.
Thank you.
Incredible.
so much.
Thank you.
Great,
Bye
great
bye.
session. Thank you
Bye.
so much.
Great.
I'm happy to
Thank
see
you
you
very
all.
much. Thank you.
Bye.
Bye bye.
Bye.